To prove that an exposure causes a disease, we have to solve what statisticians call the fundamental problem of causal inference. It requires us to observe a counterfactual timeline. We need to watch a person take a specific medication and then rewind their life, withhold the medication, and see if the health outcome changes. Because that unlived timeline is permanently invisible, we are strictly limited to observing correlations. We can see that people who take the medication have higher rates of illness, but we cannot see the alternative reality required to prove the drug was the direct cause. This mathematical limitation triggered a severe epistemological crisis in medical science by the mid-20th century. Doctors were watching non-communicable, complex chronic diseases like lung cancer surge across the population, but the exact environmental triggers remained elusive. Medical scientists were suddenly drowning in vast pools of observed correlations. They had the data showing people were getting sick, but without that counterfactual timeline, they were mathematically paralyzed, unable to definitively declare a cause. Up to this point, the gold standard for disease research was a deterministic model known as Koch's postulates. It required researchers to isolate a single specific pathogen in a lab and prove it caused the infection. This rigid, single-cause model worked for tuberculosis, but it failed completely against multi-factor chronic diseases. Without a single pathogen to isolate, researchers replaced the lab with statistics. They chased what became known as the glitter of the t-table, heavily relying on abstract markers like p-values and t-values, treating mathematical precision as if it guaranteed real-world validity. In 1965, an epidemiologist named Sir Austin Bradford Hill delivered an address to the Royal Society of Medicine, warning his peers that demanding indisputable statistical evidence had become a dangerous trap. Hill argued for a pivot in how we understand evidence. Public health, he suggested, should deprioritize the search for absolute, metaphysical truth. Instead, we needed a pragmatic framework that allowed scientists to make life-saving interventions based on the incomplete data we actually have. Hill proposed 9 distinct viewpoints to assess an association, which modern epidemiology groups into specific categories of proof. The first is direct evidence. Here, Hill defined a cause entirely through intervention. If we change an environmental exposure, does the frequency of the disease actually drop? The most immediate test within this category is the strength of the association. If a statistical correlation between an exposure and a disease is massive, the math simply crowds out the likelihood that a small, hidden variable is confusing the results. Hill pointed to Percival Pott's observation. Chimney sweeps were 200 times more likely to die of scrotal cancer than men in other occupations. An effect size that huge effectively bypasses the need to wait for definitive cellular proof before taking action. Next is temporality. Out of all 9 viewpoints, this is the only absolute, non-negotiable rule in the entire framework. The suspected cause must strictly precede the effect. Direct evidence provides a causal argument with its mathematical spine, but the numbers are ultimately incomplete because they cannot describe the physical process of how the exposure damages human tissue. To evaluate that physical process, we use mechanistic evidence. This requires the observed association to have a credible biological explanation. We don't necessarily need the exact cellular pathways mapped out, but the mechanism has to be plausible under the accepted scientific knowledge of the day. We then verify the findings using parallel evidence. Hill's viewpoint of consistency requires that an association is repeatedly observed by different researchers, in different locations, across different populations. If the effect holds up everywhere, it eliminates the chance that we are looking at localized bias. Contextual support is also drawn from analogy. Once medical science confirmed that the drug Kevidon, the litamide, caused severe limb defects in fetuses, it established a strong biological parallel, making it highly probable that other chemically similar drugs would have analogous effects. Hill never intended for these 9 viewpoints to function as a single logical thread. They act as a multi-dimensional net, designed to subject a correlation to heavy scrutiny from every angle, trapping and eliminating non-causal explanations. This diagram shows a directed acyclic graph, or DAC. It visually maps causal paths between an exposure, an outcome, and unmeasured variables. Using this structure, researchers calculate E-values to mathematically interrogate Hill's strength criterion, determining exactly how massive an unmeasured bias must be to invalidate the finding. The causal revolution didn't replace the Bradford Hill criteria. These modern mathematical models simply provide the precise algorithmic language required to execute his underlying philosophy on a massive scale. While the scientific community treats the criteria as flexible heuristics, the legal system often strucks away that nuance. In pharmaceutical liability and mass tort cases, attorneys frequently misapply Hill's framework as a rigid, dogmatic checklist to secure courtroom victories. A clear example of this failure occurred in the recent In re acetaminophen litigation. Expert witnesses attempted a transdiagnostic analysis, lumping heterogeneous neurodevelopmental disorders into a single Bradford Hill evaluation. The court rightfully rejected the methodology. Combining different outcomes into one analysis masks the evidential weaknesses of individual disorders. It directly violates Hill's original operational intent. The viewpoints are tools engineered for isolating specific, independent variables, not universal laws to be applied to broad categories of disease. Which brings us to the central, most frequently missed lesson of Hill's 1965 address. He argued that the burden of causal proof is not static. The amount of evidence required to act must scale dynamically based on the societal consequences of the intervention. This animation weighs the consequences. If a non-essential morning sickness pill is suspected of causing birth defects, the evidence required to restrict its use should be relatively slight, but forcing an entire manufacturing industry to overhaul its infrastructure requires a substantially higher burden of proof. We know this pragmatic standard works because we have already used it. Public health action on cigarette smoking was correctly initiated based on observational evidence, well before the exact biological mechanisms of lung cancer were fully mapped in a lab. Modern epidemiology is shifting toward causal pluralism. Scientific work is inherently incomplete, and our data will always carry uncertainty. But when human lives are at risk, that incompleteness is never a valid justification for paralysis.